Alrighty, class, how you doing? Going to try to add or try a different program now. I'm using Screencast instead of Loom to see how this goes here. So we're going to do Chapter 9, Cardiovascular System. And you can read through the learning objectives here, but describe the function of heart and blood vessels, diseases of the heart, arteriosclerosis, atherosclerosis, etiology, signs of arterial hypertension, peripheral vascular disease, arrhythmias, heart valve, regurgitation, a lot of good stuff here. Now, the structure and circulation of the heart. You probably have had anatomy already, so I don't need to go back and kind of give you a brief overview of the heart, but the heart has 4 chambers. So you have the right atrium, right ventricle, left atrium, left ventricle. So you have unoxygenated blood that comes from the superior vena cava, inferior vena cava. So we call that the blue blood, right? It's going to go through the right atrium. It's going to go through the right AV valve, okay? And this unoxygenated blood is going to get pumped from the right ventricle all the way through the pulmonary trunk, and then via the pulmonary arteries are going to go to your lungs. And the lungs will oxygenate the blood and then return it via pulmonary veins into the left atrium. Then it goes through the left AV valve, the mitral valve. You've heard of mitral valve prolapse or a heart murmur. Murmur is where the valves are faulty. Here's the left ventricle, which is thicker than the right ventricle, and it'll pump blood all the way through the aorta, and that's oxygenated blood. So in a nutshell, pretty much that's how the heart works. Okay, obviously things can go wrong, but your heartbeat, if you were to listen to your heart right now, it goes bump, 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 bump. So in medical terminology, we call that the lub and the dub. The lub is actually the closing of the AV valves, and the dub is the closing of the semilunar valves, the pulmonary and the aortic. So when you go to the doctor and he's listening to the stethoscope, he'll look for that lub dub, or she, lub dub, lub dub. And if they hear a lub dub sh or a lub sh dub, there might be some backflow or some regurgitation that occurs. So that's what they're listening for. Okay. And there's 3 layers of the heart. You've got the pericardium, the epicardium, and the myocardium here. Okay. Now, so the cardiovascular system includes the heart and blood vessels. Main function is transport, delivers oxygen and nutrients needed for metabolism to the tissues, carries waste products from cellular metabolism to the kidneys and other excretory organs for elimination, circulates electrolytes and hormones needed to regulate various bodily functions. So really, if you look at the real function of the cardiovascular system, it's transport. There's 2 parts. There's the systemic circulation and there's pulmonary circulation. So the heart pumps blood. Blood vessels serve as tubes through which blood flows. The arterial system carries blood from the heart to the tissues, oxygenated blood, red blood. Veins carry it back to the heart, blue blood, unoxygenated blood. Here's the system. Here's that blue blood, unoxygenated, returns via the veins. So here's the inferior vena cava. Here's the superior vena cava going into the right atrium. Then the right ventricle will pump it into the lungs. The lungs will oxygenate it, and then it returns to the left atrium and left ventricle. And it's just this closed circuit that occurs. Now, if you look at cardiovascular diseases or age-related diseases, cardiovascular disease is the most frequent diagnosis in older adults and leading cause of death in both men and women over the age of 65. Hypertension occurs in 1 out of 2 to 2 out of 3 people greater than 65. Heart failure is most frequently reported hospital discharge diagnosis among older adults in the U.S. With age, system degrades, resulting in decreased ability to respond to increases in workload and stress. Therefore, thresholds for symptoms of cardiovascular disease become more common with age. Now, you should know this. This is a great little slide that I put together, intro to the cardiovascular, but the cardinal signs, objective, and symptoms, subjective, of cardiac disease. Now, chest, neck, or arm pain is symptom. Palpitations, now that's why I put symptoms could be subjective or objective. There are some, like palpitations, could go either way, meaning, yes, they're subjective. You said, oh, my heart's skipping a beat, but we could use a machine to actually see those palpitations in an EKG. So it might work that way. Dyspnea, difficulty breathing, syncope, fainting, that's objective. Someone passes out on you, that's objective sign there. Fatigue, if you tell me you're tired, that's a symptom. Cough, I can actually visually see you coughing, so that would be a sign. Cyanosis, bluish hue, that would be a sign. I can see your face is blue. Edema, I can visually see it, that's sign. Leg pain, if you just see pain, then it's a symptom because I can't really measure it. Now, this is the very important as far as implications for the PTA. Before starting treatment, may need to assess signs and symptoms. PTA should always monitor an unstable cardiac patient. Keep intensity low and gradually increase. Monitor palpitations. If they've had caffeine, estrogen, medications, drugs can all affect the heart. Do they happen suddenly and end suddenly? It could be arrhythmias, or is it a gradual onset and then gradual disappearance, which could be normal alterations. Monitor dyspnea, that could be a sign of poor physical conditioning, obesity, allergies, and asthma. Measure if it's pulmonary versus cardiac, relief with pursed lip breathing, leaning forward. Okay, that could be more pulmonary. Syncope without warning could be heart valve related, meaning that if they faint without warning, then there could be something wrong with their heart valve. Fatigue, monitor heart rate, blood pressure, and edema greater than 3 pounds could indicate congestive heart failure. Now, what are some diseases affecting the heart muscle? You've got ischemic coronary artery disease, you've got angina pectoris, hypertensive cardiovascular disease, myocardial infarctions, congestive heart failure, orthostatic hypotension, myocardial disease, or trauma. So all of these can affect the heart muscle itself. Now if we look at cardiovascular system, diseases of cardiac function, you've got ischemia or ischemic heart disease. Basically, that's reduced coronary blood flow, most often due to atherosclerosis. So those are plaques. Ischemic heart disease, what are some signs and symptoms of ischemic heart disease, which is basically a narrowing. Okay, so what are some signs? You might get chest pain, or angina pectoris is the medical word. Angina meaning pain, pectoris meaning chest, which results from ischemia. Palpitations, a sensation of rapid pounding heartbeat. Dizziness or fainting. Weakness upon exertion or at rest. Shortness of breath. Most devastating sign is a myocardial infarction, which would be an MI or heart attack. Crushing pain in the chest, shortness of breath, nausea, pallor, weakness, and faintness. How would you treat coronary heart disease? Treatment depends on the severity of the disease as well as patient risk factors. Medications include blood pressure lowering agents, blood thinners, diuretics, meds that increase the excretion of water, nitrates, nitroglycerin to stop chest pain, lipid lowering meds, lifestyle changes such as healthy low salt diet or exercise. Some other diseases affecting the heart muscle, coronary heart disease treatment. You could do an angioplasty, which is a procedure used to open a partly occluded artery. So they'd go in there. Usually they'll go through the femoral artery or vein, depends, but usually the femoral artery. And then they'll go right through here. And then the balloon comes up and then pushes the plaque out of the way and will temporarily open that up. But if they don't change their diet and if they don't exercise, then they'll have to go back to this within 5 to 10 years, depending on the individual and how bad their diet is. Okay, so again, usually the femoral artery is where they go through this. Now, what is atherosclerosis? Atherosclerosis is a hardening of the arteries, multifaceted disease resulting from a number of insults that damage the vasculature. Risk factors that initiate the atherosclerotic process include hypercholesterolemia, so a lot of cholesterol, smoking, hypertension, diabetes, obesity, and a family history. So you can see the plaque building up, and then the red blood cells have a difficult time going through that. Now, let's go here. Keep moving me here, Atherosclerosis signs and symptoms, not associated with symptoms until the interior of the artery is extensively occluded, meaning the patient might not even know until a long time that, hey, something's not right. Symptoms depend on location, severity of occluded artery. If it's coronary, which would be in the heart, chest pain and shortness of breath. If it's the carotid, reduces blood supply to the brain, causing a stroke. So make sure you know the difference between a stroke and a heart attack. A heart attack would be blockage of blood supply to the heart, and a stroke would be blockage of blood supply to the brain. Leg arteries, so aka peripheral vascular disease, PVD, leads to pain in the muscles of the legs, severe cases resulting in ulceration or gangrene. Had a patient that had gangrene. It's not a pretty sight, I'll tell you that. Now, what are some treatments for atherosclerosis? Well, you've got control of blood pressure, reduction in cholesterol, lifestyle changes, but then there's also medications, Lipitor, Crestor, Mevacor, Lescol. So a lot of these statins, rosustatin, lovastatin, are one of the side effects of statins, and I'll tell you from patients, is musculoskeletal pain. So you'll get a lot of these patients that have heart issues, but then they'll come in with shoulder pain. They'll come in with Achilles pain. And what they've done is there's lots of studies that shows that these statins can actually damage the musculotendinous junctions. So, and if you're diabetic and you're doing that, usually leads to left shoulder pain, could lead to adhesive capsulitis. So a lot of issues with taking statins for a long time. I'll look at some of the research on there. It's not very good. So if you have a patient that has a shoulder pain and they're on statins, have them talk to their cardiologist and see when they can come off these statins. Obviously, if it's it's not our decision, but if they can talk to their cardiologist and wean off of some of these statins, a lot of times their musculoskeletal pain can go away. So keep that in mind. Now, cardiovascular system, coronary heart disease. What else can you do? A CABG. So a CABG, or coronary artery bypass, for more severe blockages, involves the rerouting of blood through the clogged arteries to improve blood flow and oxygen supply to the heart by using patient's own saphenous vein, internal thoracic mammary artery, or radial artery. Okay, so they can use, most of the time they'll use a saphenous vein. So if you see a patient with a huge scar going down their leg, they probably use the saphenous vein to bypass the heart. And so that what they can do is they can bypass right here. So see how they're bypassing that and helping with the clot there. So they're getting blood from here, and then they're going to bypass that. So that's a triple bypass. You've heard triple bypasses, quadruple bypasses, etc., etc. So they're getting blood supply to the rest of the body here. See, you have a clogged artery here, you have a clogged artery here. Well, they're gonna bypass that and then supply blood there, supply blood here. Okay. Now, this is very important. As a PTA, what do we do for implications? This will definitely be on the quiz, and so we'll end part 1 of chapter 9 with this. But post-op considerations for a CABG, or sternal precautions. You should know this for the boards as well. ACSM guidelines for 5 to 8 weeks post-op, lifting no greater than 5 to 8 pounds with both arms. Range of motion exercises are okay with lifting 1 to 3 pounds in each arm if no signs or symptoms of sternal instability. Instability signs and symptoms: movement of sternum, pain, cracking, or popping. Range of motion limited to mild pain and onset of feeling pulling on incision site. That's okay. And then check eval MD orders for specific precautions if there's anything else. Again, some more sternal precautions: no pulling up in bed. Patient must roll onto the sideline position. Use the top arm to assist pushing up while allowing feet to drop to the side of bed as a pendulum type of assist. Handheld assistance during mobilization may be required in place of a walker or other assistive device. No driving or sitting in front of a vehicle, and because of the seat belt here. Okay. Post-op considerations for CABG: full neck, shoulder, and torso range of motion permitted if sternum is stable, but not if sternectomy or muscle flap is present. If present, less than 90 degrees of full flexion and abduction, or to the point of movement of chest wall or rib cage. So usually 90 you're okay, but as soon as you start to go up and the rib cage moves, you have to be careful with that. Avoid pushing, pulling, heavy lifting with upper extremities. Progression based on patient tolerance and signs of wound healing. Sternal support may be useful to treat patient pain associated with sternotomy wounds, especially during coughing. Patient during exercise: PTA should ask the patient report all symptoms or sensations during exercise. Measure and document baseline pulse oximetry. Monitor heart rate and rhythm, respiratory rate, BP, also during and after exercise. Note any accompanying symptoms pre, during, and post. Maximal heart rate should be less than 130 beats per minute. Heart rate should return to baseline within 5 minutes. So let's say their baseline is 80 beats per minute. You do a couple exercises and they say, I don't feel good. You measure it, it's about 120. Okay, that's a normal response. We're still good. We're going to wait and see after 5 minutes, does it return to 80 or does it stay at 120? Okay, so stop exercise if heart rate's over 130 or less than 40, if their O2 sat is less than 90, if their temperature is above 100, their BP is greater than 250 over 115, or decrease of greater than 10 milligrams of mercury systolic with increased exercise. Okay, so let's say their systolic pressure decreases at a rapid rate, then we need to stop exercise. Okay, so keep these in mind. Medications: beta blockers, atenolol and propanol, reduce resting and exercise heart rate, so target heart rate may not be reached. PTA should monitor symptoms and rating of RPE. So when patients are on beta blockers, let's say you have them go up and down stairs and their baseline heart rate was 80 degrees. Well, even after doing the stairs, it's still 80 degrees. You and I know that the heart rate should increase, but on beta blockers, sometimes it's suppressed. But you see the patient, they're just huffing and puffing, they're sweating. Well, that's the beta blocker. So we go by what the patient perceives. If they say they're out of breath, if they look they're out of breath, then you go with that versus what the objective measurement is. Okay. Antihypertensives include diuretics, Lasix. They have a dual action of peripheral dilation and volume depletion that can have profound effect on post-exercise BP. Requires proper cool down after vigorous exercise to prevent venous pooling. So have them cool down by walking. Okay, so these are all very important. Pay attention to all these implications. They'll come back on quizzes, come back on the boards, exit exams, all that stuff. All right.